Morning, everybody. Friday of the BOA after a long week. Not the best time to attract a crowd, but welcome to the BOA clinical examination course. This is the fourth or fifth year we've been running it for the BOA. The BOA course is based on the Sheffield FRCS clinical course that we've run for the last 10 years. So BOA have asked us to because of the difficulty you get people getting into that course, to try and expand it and start with the younger audience and build you over your years, and hopefully through the years of attending every time over the years, then by the time the exam comes around, you have a technique that is established for you. It's also based on techniques which are written in the clinic examination techniques book. Faculty are very experienced teachers of clinical examination. They've taught clinical examination for many, many years. So listen to what they have to say because they've been handpicked in terms of their ability to teach on this course. The way the session will run is that in the morning we'll have lectures based on techniques. Remember the learning of clinical examination is based on establishing a technique early in your career and then using that technique throughout your career and modifying it only slightly, so that by the time you come to examine, by the time you come to clinical practice, it is built into your system. So the lectures will demonstrate or to instruct you on a technique that is foolproof. And in the afternoon session, you'll be divided into groups. Now, over the years, we found difficulty. This is the most difficult part for us, is to get you into groups not to get you into groups. It is for you to get into groups that you can stick with throughout. So what we thought we'll do is that we'll have two groups. One with the senior people who want to be at peri-FRCS level, and those who are those who are core stroke ST3, ST4 level. Okay, can I sort of get a feeling of what the mix of the audience is? Who are core or ST3, ST4? Okay, and who are peri-FRCS Orth or above? That means ST5, ST6 or above. Okay, so it's about 50-50, which is great. So what we'll do is we'll have Mr. Jones is going to kind of come up with a plan and get you into your groups. So this afternoon when you come back, you'll be in your groups. And the way we'll run it is that the tutor will demonstrate on one of you what he's lectured on. And then secondly, you get a chance to practice among yourselves. So it's good to pair yourself up. And then we'll use that technique to get through till 4 o'clock. Okay, we hope to finish exactly at 4 o'clock. Not after, so that most people can get their flights. The first talk will be on hip examination by Paul Panaskovich, and most of you will know Paul from his books that he writes.
Okay. Good morning. My name is Paul Banaskovich. I work at Queen Elizabeth Hospital, Gateshead. For the next 20 minutes or so, I'll be taking you through examination of the hip. For an exit fellowship examination of the hip, not only will the candidate have to demonstrate that that the examiners see and appreciate each part of their examination, but it'll become immediately apparent to the examiners if you've developed a routine. And developing a set routine in the weeks prior to the real exam will make sure that everything flows smoothly and no steps are forgotten. So exam etiquette is very important, and at the minimum, even for the short cases, you should introduce yourself to the patient, ask permission to examine their hip, ask if their hip is painful, and explain what you're going to do. You need to listen to what the examiner says, look as though you've examined the hip before, think about what you will find, and appear confident to the examiners. And at the end, you have to wash your hands between every case, and don't forget to thank the patient. So although examination of the hip should be considered a continuous process, for ease of purpose, we break it down into a number of different subsets. That's inspection, standing the patient up. That's the look part of Apley's look, feel and move. Gait, walking the patient. Trendelenburg test, palpation, Thomas test, range of movement, leg length discrepancy, special tests, and neurovascular status. We examine for leg length discrepancy after range of movement because we want to make sure that we pick up any fixed contracture because legs need to be placed in equivalent positions when we're measuring for leg lengths. So inspection from the front, does the patient stand up tall and straight above shoulders level? I look and see at this stage if the leg's externally rotated, it may indicate that there's no surface disease present in one of the hips. I also look and feel for both anterior suprailiac spines. They should be at the same level. If they're not, pelvic obliquity is present. With an abduction deformity, it's raised up. With an abduction deformity, it's raised down. At this stage, I get the patient to, I ask them to pull in the legs, feet together, and bend the knees back. And immediately, any leg length discrepancy should be unmasked. And if it's present, I might want to ask for blocks at this stage. I then look to see if there's any scars or any calf muscle wasting. I look at the feet to see if there's any deformities present and anything else positive, but I don't really want to waste a lot of time going through a long list of negative findings. It uses up a lot of time. It doesn't necessarily score me any extra marks, and it might actually irritate the examiners. From the back, I look to see if there's an increased lumbar lordosis suggesting that there's a fixed contracture of the hip. At this stage, I'll lift up the underpants and look to see if there's any scars present or sinuses. I'll also have a quick look at the knee to see if there's a contracture there as well, because that's quite a nice way to do that. From behind, is the spine straight or scoliotic? If it's scoliotic, I'll immediately be thinking about getting the patient to sit on the couch before I lie them down to see if the curve is structural functional. Is there any gluteal muscle wasting? That's a very strong indicator of hip disease. What's the alignment of the lower legs? Again, I look at the popliteal fossa. Is it equal or unequal? Suggestive of a leg length discrepancy. Is the foot plantigrade or is the verso valgus? I get the patient at this stage to bend down. This is just a screening test, forward flexion of the spine. I'm looking at the rhythm and symmetry of movement. Normally it should be quite smooth. If it's painful and restricted, I'm thinking about referred pain from the hip into the spine. Gait is next. You want to walk the patient. Ask the patient to walk away from you and walk towards you. You're looking to see if they're walking in a straight line and if their shoulder remains level. There's lots and lots of gait patterns. I think the three most important ones to be aware of are antalgic Trendelenburg and short leg gait. And you have to be quite careful if you mention these terms in the exam that you've got a definition to provide for the examiners. So with an antalgic gait, the patient avoids putting weight on their painful hip. There's a shortened stance phase. And with this, the patient leans in over to the affected side. And this has the effect of moving the center of gravity nearer to the femoral head. So it reduces the counterbalancing forces that are required to be generated across the painful abductor muscles and therefore reduces the compression that occurs on the painful hip. With a Trendelenburg test, there's a dipping down of the pelvis opposite to the affected weight-bearing stance leg. With this dropping down of the pelvis, the center of gravity shifts to the pelvis that's dropping down, and the patient usually has to compensate and they throw their upper body over to the weight-bearing leg, shifting their center of gravity again closer to the femoral head to avoid falling over. It's all to do with biomechanics, Trendelenburg, and the antalgic gait. It's moments around the hip. It's the force times distance. So you're reducing the distance so that you reduce the moments that need to be counterbalanced. With a short leg gait, there's a regular even dip of the leg on the affected side. It's only usually apparent if there's greater than 2 centimeters leg length discrepancy, and there's an exaggerated dip down and shift of the center of gravity. In contrast to the antalgic gait, it's a regular stance phase. It's not an uneven stance phase. With Trendelenburg test, this is a test that you really need to be at home with. Be prepared to be grilled about what you're doing, why you're doing it, and the significance of a positive test. The keys to success are to explain first and demonstrate what you want to do to the patient. There's a large number of different variations of the test. The original test was described with the examiner from behind, looking at the venous dimples of Venus, dip up and down with movements. Most of us feel more comfortable performing the test from in front. We can reassure the patient. We can see if the hip is painful. We can watch to see that they maintain the balance, and we can catch them, because you don't really want the patient to fall over in the exam. It's not particularly good. So there's a number of different tests. I prefer method 1 myself. That as I said, the examiner can perform the test standing up. He can be sitting down in a chair. He can be kneeling down. He can get the patient to place their arms on the examiner's shoulders, forearms or elbows, or anterior superior spine. So method 1, it's accurate because my hand's over the anterior superior spine. Patient's arms, hands rest on my shoulder. And it's quite a sensitive test, that. And it's slightly awkward sometimes if the patient's quite small, but I think if you keep practicing that, you get slicker at it and it looks fine. Method 2 is probably the best method in the clinic. It's a very accurate way, but I would urge you, sitting in a chair, you can't always find the chair in the intermediate cases, and you probably certainly won't be able to find the chair in the short cases, so I wouldn't base your test on this, because you could come unstuck. Method 3 is quite good. It's probably slightly less accurate than method 1, but you're able to demonstrate what you want to the patient quite easy, and you're standing up straight and you don't not crouching down. So it's a perfectly acceptable method. 4, some people do 4, it's sort of kneeling into the groin. It's difficult to explain what you want with the patient. You're talking to the groin and it doesn't always look good. I've seen it used, and people do it very well and very slick and get away with it. So, but you've got to be careful about that. And method 5, I'm not sure really what advantages it does offer. What I would say is that just stick with one method that works for you. So the test, you test the good side first, and you get the patient to stand on the good leg, kick the affected leg backwards. And normally the pelvis should stay level or slightly rise, and the patient should be able to hold this for 30 seconds. If it if there is some weakness of the abductor muscles, there's a dipping down of the pelvis. If all goes wrong, just think sound side sags. So the reasons for a positive test are failure of power, lever arm, or pivot. So power failure could be generalized muscular disorders, generalized neurological conditions, or more localized conditions, superior gluteal nerve injury, abductor osteotomy, hard hinge approach to the hip, that's weakened the abductor muscles. For a lever arm failure, that's really shortened neck and fractured neck of femur, coxavera, and that's again this force times distance, this moments around the hip, because there's a big mechanical disadvantage when you shorten the muscles method of action. For pivot failure, that's just the failure of stabilization of the pivot, DDH, dysplasia, destroyed hip and septic arthritis. False positives, secondary to pain, if pain isn't considered a true positive from osteoarthritis or avascular necrosis. False negatives, arthrodesed hip, the pelvis doesn't dip down. The test is invalid if the patient doesn't understand, isn't able to cooperate, has a problem with balance. There are some trick maneuvers which you need to be aware of that the patient might use. They may lean over to one side to shift that moment. So you've got to ask them to stand up tall and straight. And also they sometimes can flex the non-weight bearing leg, and this uses muscles above the pelvis to maintain the level pelvis. So be aware of that. Get the patient then to lie supine, and you want to square the pelvis. Squaring the pelvis is very important. What do we mean by squaring the pelvis? You get both anterior superior spines are level with each other and they're perpendicular to the couch. And it's important because all measurements of deformity and leg lengths are based on the square pelvis. Make sure the patient's completely flat. The couch is fairly firm, not too hard and not too soft. And ideally make sure there's no breaks in the couch as well, although sometimes you get what you're given. You want to reconfirm any previous findings, and then if there's any new obvious findings, you want to mention that to the examiners. And you're really looking for asymmetry, deformity and malalignment of the legs. Palpation is next. At least offer to palpate the hip. You probably won't be asked to do this. The problem is that the hip is a deep joint. It's difficult to feel for an effusion or any synovitis. They'll usually ask you to move on. So Thomas test is next. This is again another test that you need to be at home and comfortable to do and get on with it and do it fast and slickly. It's a test that's usually well described by most candidates, but actually poorly performed in the stress of the examination. I think one of the key maneuvers for this test is, rather than standing bolt upright doing the test, I tend to kind of kneel into the couch, as you see there, and I think that works quite well. And the test wants to eliminate any lumbar lordosis to unmask any fixed flexion deformity that's present in the hip. So you place your left hand under the lumbar spine. You want to flex up both hips and knees till any lumbar lordosis is eliminated. You test the good side first, so you get the patient to hold the affected side, and normally they should be able to completely extend the normal hip on the couch with no concerns. If the spine arches up, then pressure is relieved on your left hand, and this unmasks the fixed flexion deformity. And at that stage, you get the patient to drop the ankle onto the bed, and that's the angle of fixed flexion deformity. There are a number of caveats with this test which you need to be aware of. You don't want to be too gentle flexing up the hip, opposite hip, because you won't eliminate the fixed flexion deformity fully. If you're too aggressive, you'll flex up the hip and you'll get a false impression of a fixed flexion deformity. If they've got a painful arthrosis on the opposite side, then you need to be careful you don't hurt the patient. It doesn't go down well in the exam, hurting patients. Perhaps once you might get away with it, but repeatedly it's not so good. And also, if they've got a total hip replacement on the opposite side, you should pick this up straight away and mention that you would have some concerns about dislocating the hip. And I think in most instances you wouldn't perform Thomas tests in this situation. Oh, and the final thing, don't forget to put your hand under the lumbar spine. You know, when we test people, there's always one candidate out of 10 or 2 that just completely forget. So it doesn't look very good when that happens. So movements next. Movements is a very sensitive test for hip disease. If movements are restricted in all directions, think of TB, septic arthritis. If there's a reasonably well-preserved range of movement, but pain on terminal movement, then think of osteoarthritis. And when movements are restricted in one or more directions more than others, think of a deformed femoral head, AV or Purphy's disease. You retest for active movements first and then passive, just because it's easier to do so. And watch the patient when you're doing that. Make sure, again, you don't hurt the patient if it's painful, because, again, it's not good to do that. You can measure flexion as part of Thomas test, but I would caution you not to do so unless you're very slick and very confident that you can do that. I think you can just get muddled up trying to do the two things together. So I don't do that. With abduction, adduction, you've got to be careful stabilizing the pelvis as you get a false impression of hip movements. Extension we don't tend to do in the elderly patient. So with internal, external rotation and flexion, you flex up the hip and knee 90 degrees. Be careful, because in the first slide, the foot points laterally, the leg is being externally rotated, but the hip is being internally rotated. Likewise, with the second picture, the foot is pointing medially, and it looks as though you're internally rotating the hip, but you're externally rotating. External rotation in flexion is greater than internal rotation, 50 degrees to 40 degrees, unless there's excessive femoral anteversion. Again, abduction. I don't forget to stabilize the pelvis. That's very important. I tend to abduct the other leg. It stabilizes the patient pelvis much better, and I think it's more accurate. But again, whatever works best for you. If you want it in the midline, that should be okay as well. Abduction, true abduction should be measured with the other leg in abduction, but most of us measure with the leg in the neutral position. It's just that when the leg crosses over, it can potentially lead to misrepresentation of movement around the hip. And extension, as I said, be careful with extension in the elderly. It can be difficult to do, and in practice we don't tend to do that. You may want to offer to do extension, but examiner will probably move you on. So apparent leg lengths, this used to be quite an important part, but it's become less so in the last few years. It's really to do with the fact that you've got 5 minutes to examine the hip in the intermediate case, and there's parts of the exam that tend to get cut out to focus on other parts which are going to score you the marks. So you might want to mention the apparent leg lengths, but the examiners are probably more keen that you go straight on to true leg lengths, and then you know the difference between adduction and adduction contractures and how to measure that. So with true leg lengths, you want to, it's measured from the anterior superior spine to the median malleolus. Make sure you accurately define the anterior superior spine. It's difficult if you've got an obese patient or you've had maybe a iliac crest bone graft. I think hooking your thumb up is quite a good way to do that and find it. Likewise, make sure you accurately define where the median malleolus is. I tend to measure it at the end because I think in the centre it's a bit too variable. So be aware of that. Make sure you've used the tape measure before. Make sure your tape measure's long enough to measure, and make sure it's not sort of flimsy. That's going to the paper measuring tapes that are going to tear because it just looks a bit sort of amateurish. Legs must be placed in mirror equivalent positions because, as we mentioned, that's how we measure true leg lengths. It should ideally be from the centre of the femoral head, but it's too variable, so we choose the first fixed point, which is the anterior superior spine. So if there's any shortening, you want to quickly move on to Galeazzi's test, and this test demonstrates whether there's shortenings in the tibia or femur, and you want to get the knees flexed up to 90 degrees, hips 45 degrees, heels together, and you're looking at the knee, whether it's projecting forwards or backwards or upwards or downwards. So make a big show of looking from the side of the examination couch and also from the end as well. And you're looking, if the knee projects further forwards, it suggests that that femur is longer than the opposite leg, but it's more likely that the opposite femur is shortened. Likewise, if the knee appears higher than normal, it either indicates that that tibia is lengthened or more likely that the tibia is shortened. It's usually quite straightforward, but I've just included this slide here, and the Galeazzi's test becomes difficult when you've got hyperplastic legs, but it's been lengthened. So you're expecting it to be shorter because it's hyperplastic, but it's been lengthened. And then if you've had epiphysiodesis done on the opposite side, but we can talk about that in the clinicals this afternoon. That's just when it becomes difficult, and that's that's the next level, which we can talk about. Bryant's triangle test. That test for supratrochanteric shortening. It's a test, I don't think you'd be necessarily asked to draw it out on the patient. It's a bit messy and you've got 10 candidates, but you might be able to need to demonstrate it with a tape measure or just with your fingers. And it's really, you drop a line from the anterior superior spine onto the bed, you feel for the greater trochanter, and a line is measured upwards from this, and it meets that level C, or point C. And then you draw a further line from the anterior superior spine to the greater tuberosity. So you've got an equilateral triangle, and you're looking at both sides for equivalence. And if there's supratrochanteric shortening, there should be a shortening of the BC level. It's not always that helpful if there's shortening both sides. You might just be asked about the principles of Bryant's triangle test: thumb over the anterior superior spine, index finger over the greater tuberosity, and main finger over the greater tuberosity, index finger over point C, and you're looking for any difference. And you get supratrochanteric shortening if there's like fractured neck of femur or septic arthritis. You're moving on to Nolato's test. This is just a line that's drawn from the anterior superior spine to the ischial tuberosity, and normally the trochanter should be below or just at the line, but if it's above, it suggests shortening. There's some miscellaneous tests you might be asked. Impingement tests are becoming much more common: anterior, posterior, and Faber test. And for contractures, Olber's, Illy's test, and Phelps test. I think what we'll do is we'll probably just go through these in the afternoon for sake of for time. And don't forget to examine the lumbar spine and knee. Test, mention neurovascular status, thank the patient, and wash your hands. Any questions? You could catch you at coffee time if you like.
Take one question for
Yeah,
So you have 5 minutes in the intermediate case for examination.
and short cases as well, yeah.
Short case as well. When you're measuring the range of motion,
Uh-huh.
you said active and then passive.
Active, then you quickly move on to passive for ease of purpose and ease of time.
Can you skip active or you have to ask patient to do active first and then you...
At the postgraduate level, you're allowed to skip active because usually the examiner wants to concentrate on some aspect of it. Okay. In the hip joint, you're allowed to skip active.
Okay, thank you.
Slides, please. Yeah. Morning, everyone. Morning, everybody. My name is Paul Haslam from Doncaster. As it's my birthday, I thought I'd share in the goodwill, and there's a £5 prize, English, Northern Irish money, to spot the deliberate mistake that I've put in the video. And it will, I've given you a clue now in the presentation. So to win that, you've got to put your hand up at the end, and I'll choose somebody. So keep it simple. Under pressure in the exam, you're going to have a simple system that you can rely on. Think globally, regionally, and locally, and practice. The knee's a brilliant joint, clearly the best one to practice on. You can palpate loads of structure around the knee. Just practice all the time. Develop a system and stick to your system. Always do the same thing, no matter what patient you're presented with. Stand the patient and look. Walk the patient and look. Sit the patient down and look. Lie the patient down and look. I keep going on about it. Look at the patient. Don't dive in and get your hands straight in there. So, we're going to start, I'm going to look at the patient from the front. The patient stood up, and you're going to assess their lower limb alignment. If they've got a valgus knee, like this example, ask them to stand with their knees together. If they're varus, ask them to stand with their feet together. That accentuates the deformity. If you've got a valgus knee, you can't stand with your feet together. Assess the quadriceps bulk, the fusion. Don't forget the back of the knee, and all the other things that we've listed there. Look from the front, look from the side, and look from the back. And don't miss obvious clinical deformities. You may have unilateral or bilateral deformity or windswept knees. Whilst they're in this position, you can assess for the Q angle and also for rotational alignment. So this patient clearly would have internally rotated femur, the foot's inwardly pointing, the patella's inwardly pointing. So you should already be thinking, later on I'll be doing rotational profile, I'll be assessing bait and score. Can we start the video, please? Walk the patient. Gait is a great place to trip yourself up and make a mess of it. So again, keep it simple with gait. This patient's got a lateral thrust. He's got varus knees. You've all seen lateral thrust. Just say he's got lateral thrust. My preference for gait is to skip it as quickly as possible. And in the knee, you're only going to find a nostalgic gait, a stiff knee, possibly a foot drop, and that's about it. Know those. Don't get bogged down with rockers. You can easily confuse yourself and move on. Don't forget about walking aids. And if they're in a wheelchair, ask them if they can stand and walk. Can you start on the next video, please? Next thing we're going to do is sit them down. And we're assessing, really, the extensor mechanism when they're sat. Assess the patella height, the tracking, crepitus, and active range of movement. You don't need to touch the patient at this point. You can look. That's not the average patient. He presented 7 months after a dislocated patella, and he was playing football, doing normal things. So we're going to lie the patient down. This gives you another opportunity to look. Sometimes when they're stood up, there might be a shadow, you might not be able to see little scars. So look again when they're on the couch. At this point, I screen the hip. So just give the hip a quick rotation. So just showing the examiner you're thinking about the hip. And then assess all the things we've listed: quadriceps bulks, scars, swelling, effusion. Specifically addressing quadriceps wasting, measure from a fixed point, either the anterior, superior iliac spine or the tibial tuberosity on both sides, and compare. And practice doing it. If the first time you've measured the quadriceps bulk is in the exam, you've clearly made a mistake and it won't look slick. So we're going to move on for tests for effusion. And in real life, in clinical practice, an effusion is a really important thing, because if you've got an effusion, you've got something wrong with your knee. It's also important in the exam. So for a small effusion, you do a swipe, wipe, bulge test, whatever you want to call it, I don't really mind. You empty the medial side and you push back from the lateral side and you see a bulge on the medial side. Make that look slick. Patella tap, you're pushing the fluid down from the suprapatellar pouch, and you're piano keying the patella against the trochlear. Allotment test is for a massive effusion, you're just feeling a fluid throw from side to side. The knees are brilliant. So at this point, we can now, having done quite a bit, actually start to examine the patient with your fingers. Get them to flex to 90 degrees, that opens up the knee joint, and it makes palpation easier. At this point, have another look, because small, well-healed arthroscopy scars may be invisible, and I do a little cheat here, and I say to the patient, have you had an arthroscopy? Or something like, if you may see a little scar, ask him, because it may not be healed. Palpate the landmarks and know what you're feeling, and don't forget about the back of the knee. Don't miss obvious things like Osgood-Schlasser's disease, and start systematically, go distal to proximal, feeling along the way, as you do. And know where the medial femoral condyle is. Know what you're feeling. Know the joint line. We're going to lie the patient down now and move the patient. This is where I see my registrars make a mess of it, because they're desperate to do it themselves. Well, you've got a patient there who can move his leg. You already know that. You've got information. You've seen them, they can bend their knee. So get them to do it first. Get them to do a straight leg raise. Straight leg raise is really important, because I see loads of missed quadriceps tendons in my practice. So in real life, don't forget about straight leg raising. And in the exam also. And get them to do it. Get them to flex the knee. And if they've got full range of movement, you don't need to try and squeeze that extra little bit of movement out of them. And you can hurt the patient, so be very careful about squeezing that extra bit of flexion in a knee. Look for extension and quantify and compare with the opposite side. Measure it, and again, get used to measuring range of movement, so you're not doing it for the first time in the exam. So, full extension, flexion, compare with the opposite side, and check for hyperextension. There's different ways of assessing ligaments. I like to do cruciates first, then collaterals. If your system is collaterals first, then cruciates, I don't mind. But what you're interested in, sorry, go back one, is laxity and endpoint. Patients complained of instability, but you assess for laxity. And I want to know what the endpoint feels like. I would start with the posterior cruciate ligament, put the knees together at 90 degrees with the heels together. And the examiners often talk about having a pencil against, so this obviously is sagged, the tibia is behind the femoral condyles, and this side is normal. Do your posterior draw and your anterior draw. So you can clearly see, I think I've confused it now, movement. The quadriceps active test is like that, but you have your hand down here, and you'll ask the patient to contract, and you'll see the movement. And this, can you start the video, please? This is what it looks like inside the knee. So this patient was referred to me with an ACL deficient knee. His ACL looks lax when it's sagged, but it's actually a PCL deficient knee. That's really common still. They get confused. So that's what you're doing when you're doing when you're bringing that knee back from the sag position back to neutral. Lachman's test is a better test than anterior draw for instability, and the maximum amount of instability is at 15 to 20 degrees. So you're fixing the femur, and you're moving the tibia forwards on a fixed femur. You can do it like this with your thumb, but I prefer, start the next video please. I prefer to do it with my knee involved. So I get my knee underneath the patient, underneath the thigh, fix the femur down and pull forwards. If you've got a very big patient and you've got small hands, you can ask the examiner to help, and you can use 2 hands. That's allowed. So we're looking at the amount of tibial forwards movement we're getting here. Pivot shift test, again, I'll be careful about doing this in the exam, but you should know about it. You probably should say, I'll do it under anaesthetic. Can you start the video, please? So, extend the knee. You're applying an axial load, internal rotation, valgus stress, jump, reduced, dislocate. reduced, dislocated, reduced, dislocated. You need an intact medial collateral ligament, and the iliotibial band moves from being a flexor to an extensor as you get that subluxation of the tibia. Then move on to the collateral ligament examination. The medial collateral ligament's easy. Anyone can examine the medial collateral ligament. In full extension, if you've got instability, that means it's a combined injury. In 20 degrees of flexion, not 30, that's not the deliberate mistake. Assess for laxity and endpoint. The lateral collateral, if you're Nick Harris and you're 6'3", you can do it like this. But you can actually make a mess of the lateral collateral ligament quite easily. And I think that's one of the discerning things in the examination, how you examine the lateral collateral. I'll talk a bit more about that later in the afternoon. There's a number of different ways you can do it, and it depends on your size, patient size, and get a good way of examining the lateral collateral, because you can look odd, look like a clown, really. So further tests will then depend on which way you're going with this patient. One of the patients we saw had clearly a problem with the patellofemoral joint, so you focus on that. Patellofemoral tests, again, all of these can be painful, so be careful. You should know about them, but not necessarily do them all in the exam. Patella apprehension should be done in flexion. Don't dislocate the patella, and always look at your patient. Mr. Ellie's deliberate mistake is not looking at his patient when he did that. And then, so this is patella glide, so you're assessing the amount of excursion of the patella. We normally assess it in quadrants. Meniscal tests, McMurray's test is 50% sensitive, so that's right half the time. But you should know about it, and you should know one. Everyone's got their own way of doing McMurray's. You do it one way and stick to it. Basically all you're doing is you're compressing the meniscus somehow. In flexion and extension, you vary the movement. I flex it, I rotate, and I extend. And you're listening for a click rather than pain, and look at the patient. The dial test, so if this is an instability case or a ligament injury case, you'll put the patient prone. Yeah, I know you can do the dial test supine, but for the exam, do it prone. Put them prone, do the dial test with both legs together in 30 degrees and 90 degrees. At 30 degrees, if it's just an isolated postlateral corner, it'll be positive. At 90 degrees, it'll be PCL and postlateral corner. Don't forget the hip. Don't forget distal neurovasculatus, and you should know Baton's score. Should be another slide. Here we go. Common mistakes that I see. I've done this for a number of years. When looking at coronal plane deformity, so have the feet together. If you're slightly varus, you'll notice it if the feet are together. Don't say the MCL's lax in an arthritic knee. It's not. It's correcting the varus deformity. And don't underestimate fixed flexion deformity. Everybody underestimates fixed flexion. It talks about lateral collateral. We've talked about don't diagnose a PCL as an ACL. So if you do your PCL first, you won't make that mistake. And don't get phased if you see a patient who's got a syndrome, who's in a wheelchair, who's got an orthosis. Do your routine. If they're in a wheelchair, ask them if they can stand and walk. Oops. So your routine, 6 steps. Stand and look. Walk and look. Sit and look. Lie the patient down. Look again. Move. And assess your ligaments and any other special tests you need. Okay. Spot the deliberate mistake. That's not my... Well, good question. Well, it's the mistake that I think I've made. Nothing like feedback, is there? Go on. Thanks for your feedback, but it wasn't the mistake I was thinking. Only through feedback can you improve. Was it? No, that wasn't it. It was on one of the videos.
The spike test to show on the medial center and left side.
You know, this is really interesting. You spotted loads of mistakes. No. Pardon? Should have had shorts on. No. Lackman's test. The first time I did it twice in the video. Did you notice the difference? When I flexed the knee too much, it didn't move. So common mistake the registrars make is they flex the knee to about 45 degrees to do Lachman's. Right, it took me £5. It's my birthday. And it should be 15 or 20 degrees. So, anyway, thanks.
Okay, are we still all awake? So now to the foot and ankle section. Paul made a very valid statement. When I went for my exam many years ago, as I walked into my long case, I saw a cerebral palsy patient. And I straight away said to myself, God, I'm going to fail this exam. And I quickly said to myself, get yourself together. And the exam went very smoothly. So don't be faced when you see syndromes or complex cases. Just gather yourself and go for it, and you'll be fine. So the foot and ankle, you've heard about the hip, you've heard about the knee. There's going to be a lot of repetition to what you've had. But remember, the foot and ankle is many joints together. It's a complex area. So you have to have a system and go through it systematically, and you should be fine. So, like we've had, it's all about look, feel, move. But in the foot and ankle, if you look carefully, most situations you'll come to a diagnosis or more or less have an idea what you're dealing with. So have a good look at the patient and have a good look at the feet or the ankle, depends on what you're examining. So that's your system. You've heard about look. When you look standing, look walking, look sitting. Then go on to palpate, move, and then you can do your special test as required. So when you approach your patient, it's different between clinic and exam. In clinic, the patients will walk into you. So as they walk into you, you look at them. In the exam, most patients will be seated. So as you get to them, you have to get them to stand. And you have to be polite and say, please, can I get you to stand? You may be told, sorry, patient cannot stand. Examine them sitting. But it's always good to get them to stand. And as they stand, you must be seen to be looking very carefully. Now, look from the front, look from the sides, look from the back, okay? Because certain things you may not see when you look from the front. You may not notice a severe valgus deformity when you look from the front. You may not notice the 2-minute toe signs when you look from the front. Looking from the back, you may not notice a severe hallux valgus deformity. So front, sides, back. And tell the patient gently, can you please stand around? Can I, and look, and you notice all the things you need to look out for. I just developed a mnemonic, the A, B, C, D, E, and these are some of the things that you must be looking for. Look at the alignment, the attitude. You can see the severe valgus here in this leg compared to that. Even both sides are the same. Look for body prominences. This is quite obvious there, but if you look from the back only, you may not see it, okay? Look for scars, and I tell you, lots of people miss scars, and scars will guide you a lot in your exam. And some of them are very subtle, okay? But be seen to be looking for them. And here you see the scar for hallux valgus surgery. It's not very obvious, but it's there, okay? And they do fade away well, so you may not always spot them. Look for deformity. Look at this forefoot. Multiple deformities, not just one. And please, when you comment on deformities, do it in a systematic fashion. So either you start from the big toe and work that way, or you start from the little toe and work that way to describe the deformities. Don't just go, I can see a hammer toe, I can see a claw toe, I can see a hallux valgus. Start there, and move in that fashion. So the examiner knows this guy knows what he's doing, or girl. Okay, and then look for erythema. You see here erythema. There is some swelling, and this patient has gout. You may not see gout in the exam, but yes, this patient has gout, even though they've had previous surgery with a scar. So you look standing, and while standing, if you notice certain features of abnormalities, and examples include pes planus or cavus foot, at this point, you can then focus your exam in the line of what you've noticed, okay? In this course, we are teaching you how to do it completely, but go along with what you see. So if you notice pes planus, just continue the exam in the line of pes planus, okay? Or cavus foot, continue in that line. You see people come to the exam and they're being asked, what do you see? And they go back to basics and go, keep going, keep going. What have you noticed? Stick there and just go through the exam, because you only have 5 minutes to get to the end point for what you noticed. So if you see pes planus, these are some of the things you must be thinking about, okay? Think about Baton's signs, especially in the young ones, even though adults may also have a flat foot with ligamentous laxity. Think of the 2-minute toes sign. Okay. In the normal person, you expect to see 1.5 toes. If you see more than that, then yes, it fits in with your pes splenus. And usually, for many patients, you will notice about 3 or 3.5 or even more. You then go on to get your patient to tiptoe. Please, when you tiptoe the elderly, always find a surface you can get them to lean their hands against. Don't do it in the middle of an area, exposed area, because they may tumble. And if they tumble and miss a step or fall, you cause them more pain, you cause them more aggro, you upset the patient, okay? So find a surface they can lean their hands against, go double, and then ask if they can also do single. You find a lot of elderly patients who have tibialis posterior or middle-aged tibialis posterior insufficiency may not be able to do a single leg toe rise. And we'll demonstrate this in the afternoon section. Then also check for subtalar movement. Just a caution here, if you see children with flat feet or pes splenus, please don't start talking about tib post insufficiency. Many, many candidates make this mistake, and it demonstrates your ignorance to say, guy, you don't know what you're dealing with, okay? So do not go that way. Think about tarsal collision, flexible flat foot. And if you're thinking tarsal collision in a young patient, you must be shown or show the examiner you know how to examine for subtalar joint movement, because that can give you the clue or the answer. So, in this case, look at this picture here. You can see when this patient tiptoes, the left side still remains in severe valgus, so it doesn't correct. So this is stiff compared to that side. That side corrects to a reasonable degree, though not fully. Okay, so moving on from pes splenus, now go to pes cavus. These are two different things. For those who don't know, I'm sure you all know, pes cavus is a foot with a high arch, okay? And this is one place you must do your Coleman block test, okay? The foot is likened to a tripod. The first ray, the great toe, the first ray, the fifth metatarsal, the fifth ray, and the hind foot. And in these patients, their first ray is usually plantar flex. So they tend to compensate by tilting the hind foot into varus. And the reason for doing the Coleman block test is to see if the hind foot is flexible or not, okay? If it's flexible, the Coleman block test will correct. The hind foot will go into varus. Go into valgus. So look at this case here. This is a Coleman block test demonstrating, and you must always offload the first metatarsal, okay? People make that mistake by keeping the whole forefoot on the block. So offload the first ray, and as you offload the first ray, you find in this case, it corrects to neutral, okay? So in this case, it is a flexible deformity, and that would dictate what you may wish to do surgically for this patient. Also, think neurological. Say to the examiner, I'd like to examine this patient neurologically. He may then say to you, sorry, we don't need to do that in this case. Everything is normal. But be seen to be thinking. And look at the patient's hands, because many of these patients may have Charcot-Marie tooth or some other neurological condition. And if you look at the hands, it just gives away the diagnosis. You look at all the severe muscle wasting, okay? So always be seen to be looking that way to show that you know what you're dealing with. So while standing, you can also assess range of movement very quickly. You can get them to tiptoe, go up on their toes, and go up on their heels. And this can also sometimes tell you if they have a stiff joint in addition to what you already have noticed, okay? It's because you may see an asymmetry between the two sides. So look while standing, look whilst walking, okay? Look at the rhythm, the cadence, attitude, symmetry, and stability. And you may notice that the patient may have an externally rotated limb as they walk, and this may be due to a stiff ankle or some other pathology. They may have a high stepping gait, which may be due to some nerve abnormalities, a problem with their back, foot drop. They've had surgery in the past, the nerves have been damaged, they presented to your clinic with a foot drop, and hence a high stepping gait. Or they may have a tibialis posterior dysfunction with a medial arch collapse, which may be so obvious as they walk, as opposed to either just sitting. Then you get them to sit down, because you must always be seen to be looking under the foot and between the toes. And if you look at the patient carefully in this case, you see the scar here, and you see these ulcers, okay? And once you start to see these, straight away you can be thinking this patient may have diabetes or some neurological condition that they cannot discern the sensation is poor, okay? So you'll miss things if you don't look that way, okay? Also, whilst looking at the patient, look around. And you may have done this when you just entered the room. Look around the patient. The first thing, are there any orthoses, any braces, any special shoes, any walking sticks? Because when you comment on these, it gives you extra points. If you don't comment, he may then say, what about those things lying there? The examiner says, and then you feel like, oh, I'm so stupid, I didn't spot these. So look while sitting before you move on to the next part of your examination. Palpate. Focus on the area of the pathology. So if it's forefoot, palpate the forefoot. If it's ankle, palpate the ankle. And please know your anatomy. Don't go palpating the medial malleolus and say this is the navicular. Or don't palpate the navicular and say this is medial malleolus. Don't palpate some tendons and say you palpate on the extensor aspect and you call that a flexor tendon, okay? So know your anatomy and know what you're palpating. Whilst you palpate, so bony landmarks, tendons, you must also, at some point, palpate for neurological status. So pulses, okay, and know which pulse you're palpating, and also areas of sensation. So know which nerves you're feeling, which nerve supply, okay? Common perineal, deep perineal, superficial. So know which ones you're dealing with. Then go to move, okay? When you start to move, again, have a system. Either you go from proximal to distal, okay, so from the ankle joint, distally, towards the toes, or go from the toes towards your ankle joint. Again, depends on which joints you've been asked to focus on or what the pathology is. Again, we talked about this. Do you do active? Do you do passive? In most situations, we go straight for passive because the examiner wants to see that you can demonstrate how to examine, for example, the ankle joint or the subtalar joint. Active mostly if you suspect some neurological condition or if the patient has a very stiff joint. But you can also discern that if you do passive. And because of the multiple joints in the foot and ankle, you must be seen to be isolating or excluding other joints from your examination because certain movements involve a number of joints working together. So, how do we examine for range of movement? We'll show this more this afternoon, but these are just a few points about examination of joint movement. Ankle joint is one joint that is not easy to examine because you could be showing all the movement from other joints and not specifically the ankle joint. So one of the most important things to do is your patient must be comfortably seated with the foot flexed, the knee in a flexed attitude, okay? And as you do that, as you go ahead, you must keep the forefoot supinated to exclude movement from show-pass joint and keep your hind foot in an inverted position to lock out the subtalar joint. And one way of doing this easily is to keep, you can see what I'm doing, one hand under the foot, inverted, supinated, and the other hand here. Look at the patient's face, and then you plantarflex and dorsiflex gently. Okay, and by doing this, you can be certain you are getting movement from the ankle joint and not other joints. So that is the ankle joint for you. Subtalar joint, another difficult joint to examine for many people. And again, here, what you want to do is to exclude movement from your ankle joint, but also from your show-pass joint, even though some of the movement will come from your show-pass joint. So you can see here, the examiner has his left hand on the neck or head of talus, and you must be seen to be stabilizing the talus, okay? Otherwise, your movement will be partly from the ankle joint. So here, you lock out the ankle joint by holding that your talus firmly, medially and laterally, and then you hold your foot, hind foot, and then you evert and invert, okay? And this is subtalar joint movement, okay? And lock, you keep the rest of your foot supported in your hand, in the palm of your other hand. We'll demonstrate this afternoon. Show-pass joints, again, some of the movements from these joints, that is a talonavicular and calcaneal cuboid as they work together, may link to the subtalar joint. So you can see here carefully, one hand stabilizes the hind foot, and the other hand stabilizes the mid-tarsal joint so that you can just test your show-pass joint. And movements from this area will be pronation, supination, a degree of abduction and adduction. And the movements of abduction and adduction are very subtle, just about 5 degrees either way. So this is your Chopin's joint. Going on to the metatarsal joints, again, very limited movement here. You just move your hands along. So here, you can see the right hand is stabilizing the calcaneocuboid joint and the talonavicular joint roughly, and then you move your other hand just distally, okay, before the metatarsophalangeal joints, and then you test the movements there. First ray, again, some of the patients may have hallux valgus, some may have hallux rigidus, okay? So again here, one hand must be stabilizing the metatarsal, which you can see, it may not be very clear here, but one hand has to be on your first metatarsal, and the other hand must hold your great toe just proximal to the interphalangeal joint, and then you move that joint and watch the patient as you do so. And if you suspect hallux rigidus, then you may go on to do your grind test, but do it carefully and gently because the patient may be in a lot of pain when you do that. And that's a rotatory movement with compression on the joint. The lesser toes or lesser rays tend to move together. Okay, they move, so your second, your third, your fourth, your fifth move en masse. So if you're focusing on a particular toe, which you may be asked to do, then you must be seen to be locking out the others and keep just testing that joint. And one of the things we do with toes is that you must decide if the deformity you see, for example, a flexion deformity, is passively correctable or fixed. Because if it is fixed, then your treatment of choice or your surgical treatment may vary from if it's passively correctable. And we'll demonstrate that later on this afternoon. Muscle testing. Again, this is one place where people tend to fall down. Okay? So we're starting from the tibialis anterior, moving on to the peroneus longus. I chose these three because these are the most common. So here we're testing the tibialis anterior. And what you must do, your patient seated comfortably, get them to dorsiflex the ankle and invert. Okay? And you can see one hand is on the tendon to feel contraction of the tendon, and the other hand is to try and tell your patient to hold the foot there, and you push them laterally or evert the foot. And as you do this, you'll be testing your tibialis anterior. Okay? Your tibialis posterior, slightly opposite, so the patient plantar flexes. Okay? Again, inverted. You tell them to resist your action by you trying to evert them or push laterally, and you keep your other finger or finger of the other hand on the tibialis posterior tendon. So don't go anteriorly at the back of the medial malleolus. Okay? And this is a peroneus longus. With the peroneus longus, you have to plantar flex the foot and evert. So get the patient to plantar flex and evert, and you tell them to hold it there, and you try and push the foot away from that position. Again, you see I have one finger on the peroneus longus. With the peroneus brevis, you keep them in neutral and you evert. Okay, so that's the difference between brevis and longus. Special test then, if you may be asked to test the Achilles tendon. Okay, so this is, you're unlikely to see Achilles tendon rupture in the exam, but you may be asked to examine a patient for Achilles tendinosis. And this is a Thompson's test for Achilles tendon rupture. I'm sure you all know. I won't go into that. Ankle instability. Again, ankle instability is not very common, but occasionally you get asked. You either do the anterior draw or you do the varus stress test. The anterior draw testing your anterior talofibular ligament, and your varus stress testing your calcaneofibular ligament. Okay? And get your patient seated comfortably and relaxed. This test can be very difficult because if the patient is in pain, they'll resist you doing it, and it's usually best done with some form of anesthesia. Anterolateral impingement. Again, this test, you get your patient to plantar flex, have a finger of yours or your thumb apply pressure to the anterolateral aspect of the ankle joint. As you do so, watch the patient's face. They may have some pain, and then when you dorsiflex the ankle, the pain may increase with your finger kept in that position. So this is for anterolateral impingement. Sorry. So that's the end of the foot and ankle examination. It's all about having a system, as you've had, and going through that system. But remember what I said. Once you spot your pathology, please go straight there and don't beat around the bush. Otherwise, the examiner will say, what next? What next? And you start to panic. Okay, thank you.
Ankle stability test, do we have to do it part of?
No. Most ankle, foot ankle cases, you may be asked to examine the ankle joint for instability is rare. You examine the ankle joint, examine the forefoot, and you will see some deformities there. You may see hallux valgus, notice stiffness of the MTP joint, the big ray, not hallux rigidus. You may notice a flat foot. So it's unlikely you get those type of cases.
I mean, as part of the condition that they had, they may develop ankle stability. After collision.
If you feel, but usually the time, no, tarsal collision, they'll be stiff, so they won't develop. Yeah, the time will run out. You won't get to that point.
Very,
Have
very
you?
rarely you get.
Yeah, I've never seen anybody get to that point because 5 minutes is so short. Yeah, go ahead.
There's one of the tests that's described where you hold the lesser metatarsals
Yes.
in dorsiflexion, so you kind of make a plantigrade foot. Is that for testing range of movement? Or
Well, say that again. What was your question?
I can't remember which test you need to do this in, but you have to push against the lesser metatarsals to examine the first ray. Is that for instability or is it just for the range of movement?
No.
Is that, yeah, probably multi-clicking is something for
Modest click, you squeeze. I don't know what, but when you're testing the lesser rays to see if you have, for example, a second toe deformity, flexion deformity. I don't know if that's what you're saying. And if you want to see whether it's flexible, sometimes when you push the foot up, is that what you're saying? When you push the foot, dorsiflex the foot, you relax the tendons or you stretch the tendons. So as you do that, the deformity may correct. Is that what you're saying? I think that's what you're trying to
Some people do Peronis longus like that.
Yeah.
That's an inversion. You should put your hand on the outer side of the foot, and then you feel the first ray because Peronis longus goes around inverting to insert into the first ray. That some people will examine the Peronis longus like that.
Okay, I'll pass you on to the spine section.
One of the benefits you have here is that most people here who are tutoring you today are examiners or very experienced teachers of clinical examination, so they've been around for a long time. So listen to what they say.
So we're going to move on to the spine. It's important to remember that the examination is just part of your assessment. There's the history and investigations as well. And a lot of what we've been talking about today is pattern recognition. So if they've obviously got a flat foot, for example, you're going to concentrate on that, and it's exactly the same in spines. And there are some classic cases. If you see a patient who's got an obvious scoliosis the moment you look at them, examine the patient for their scoliosis. Don't get waylaid. One of the problems in the exam is there's something clearly and obviously wrong, and you go off on a tangent doing your whole encompassing examination, and the examiner gets irritated. So there are some classic cases that come along, and you need to know about some of these. The history will tell you most things, and the examination is either just to confirm that, confirm your clinical impression, or suddenly it makes you think again, ooh, could this be something else? You need to focus in and widen out when you're examining a patient. Today is all about how to structure an examination, eliciting physical signs, some interpretation of those physical signs, and whatever you want clearing up. And we've talked a little bit about the exam, but the short cases is all eliciting physical signs. Sometimes you'll be asked, can you examine this patient's hip? But you might be told, this patient has an unstable ankle, show me 2 tests, for example. So always listen. And so the short cases are all about eliciting physical signs. And in the exam, there are good candidates who can do a focused and clearly good physical examination in just a short time, and the learner can do the same thing in under an hour. Some things not to miss. Not all groin and thigh pain is an L2 radiculopathy. It could be a hip, it could be a whole stack of things. So always think of some other things. Diabetes, think of neurological disease. Don't jump to conclusions. Shoulder pain. In the exam, you occasionally get patients with neuralgic amyotrophy, Parsonage-Turner syndrome, so think of those. This is a very good resource, and a lot of the rest of my lecture is taken from Fazal Ali's lecture, which incorporates pictures from his book. That's a pretty good book. So Graham Apley, look, feel, move, special tests. You've heard that from every lecturer today, and that's the way to do it. Even if you know nothing, if there's some structure to what you're doing, the examiner may still be fooled, as may the patient. For starters, always think about whether you need a chaperone. Exposure, you have to expose the patient fully to see some physical signs, and you have to think, am I going to do this examination with them standing or lying or sitting or what, or in what order? The examiner gets irritated if you walk the patient, then lie them on the bed, then stand them, then lie them on the bed, then they're up again, and so you have to tailor it. You need to expose the patient, otherwise you'll miss things. You need to be able to expose the top of the neck, Klippel-Feil syndrome, or an Arnold-Chiari decompression or something like that, and at the base of the spine, sacral stigmata. And you don't in the exam, you just need to not really just make a show of it, but just pull the top of the pants down, or on the hip, pull the side of the shorts up so that the examiner thinks, good candidate, they're looking for the things that might be missed. And incredibly, you might have missed something, so it pays off. So you have to have a routine of how you're going to examine the patients. And my preference is for the lumbar spine. You see them walking, and as a couple of the other examiners have said, in the clinic, you see them walking down the corridor to you. And in NHS clinics, they're all lino floors, and so you can hear their foot drop gait. Trouble is, in the private hospital, you can't hear the foot drop gait. And then you can observe them walking across the clinic room to you and so forth. But in the exam, I'm going to stand the patient and walk them, and if the examiner wants you to do that, they'll get you to do that. Examine the patient standing, then for the lumbar spine, lying supine, lying prone, and sometimes sitting them on the edge of the bed. Cervical spine, walking, standing, sitting, and for neurological examination, lying supine as well. So you just have to have an idea. So you're going to stand and look, and what are you looking for? You're looking for things like deformity, steps in the spine, scars, stigmata, discoloration. From the back, you're going to look at coronal balance, asymmetry. Are there creases? Are the shoulders level? And if there is any asymmetry, you might start to ask the examiner for a plumb line or something, and he'll say, no, don't be so silly, and just move on. Look from behind, look from the front, look from the side. And it's quite useful to get the patient to turn, because sometimes they might be okay standing up, but the moment they start to turn, they may hobble or something. So get the patient to turn gives you useful information. Look from the front and in the axilla. In the axilla, you may see freckles or something. The examiner's quite like you looking in the axilla. Look from the side. Look for sagittal balance and sagittal plane deformity. And these are from Fazal's slideshow. And you can see all of these patients have some deformities. You just need to be sure what you're looking at, and be able to describe them properly. And remember that apparent hyperlordosis of the lumbar spine can be secondary to hip fixed flexion deformity. Look from behind, and you're going to be looking for curvatures in the spine. Know what you're talking about. Scoliosis, you need to be able to define what a scoliosis is. You need to be able to talk about kyphosis, loss of the normal lumbar lordosis, and just describe what you're looking at. And that's often the starting point. If you can describe what you're seeing, then that's half the way to getting the correct diagnosis. And if you jump in straight with this is a scoliosis, the examiner may take you back a step. Hold on, just describe what you're looking at. And that's very important. And sit the patient down at some stage. Adam's forwards bending test. This is shown here. Bunnell angle using a scoliometer. So if you stand behind a patient and say, I can see there's malalignment in the coronal plane. I think this patient has a scoliosis. I'd like to just check their forwards bending test. The examiner will be quite happy with that, because you've moved on to do the next stage of a scoliosis examination. Sorry. Always be aware that if there's a leg length discrepancy and a pelvic tilt, there'll be an apparent deformity of the spine, and you can just check on that by sitting them down on the edge of the couch. So that's looking Because in the lumbar spine, you can't really palpate next with them standing up. You do the palpation when they're lying on the couch. I go on to moving the spine, and you're looking for stiffness, you're looking for deformity that's disclosed or abolished with them moving, and you need to know whether they're in pain. This is forward flexion of the lumbar spine. You should always be aware that patients can have very stiff lumbar spines, but very mobile hips, so always have a think about where the movement's occurring. I always look at them from the side initially, and some patients with ankylosing spondylitis can touch their toes, but there's nothing in the lumbar spine, it's all in the hips, so just be aware of that. But if you do want to measure it, have a think about how you're going to record it. In real life, almost no one does Schober's test in the clinic. They record it fingertips to mid-shins or something. But if you want to do Schober's test, we'll go over that. Think about that, and think about what's meant by an extension catch. We might talk about that this afternoon. Extension of the lumbar spine. How is this recorded? And what does pain on extension mean? Lateral flexion. How are you going to record this in the notes? And rotation. Well, where's that occurring? Is that in the lumbar spine? You need to know where some of these movements occur. Neurological examination, while you can do a little bit of it while they're standing up, so just get them to tip back on their heels or stand on tiptoes, particularly if you think there is a neurological problem coming up. Then, having done that, you need to lie the patient down. It's always quite sensible to always just put a hand on the tummy if they're lying on their back. It's always very embarrassing to miss an aortic aneurysm, which you only pick up on the lumbar spine x-ray. So always think of that. Palpate the spine, palpate the pelvis. You need to go on to a neurological examination, and you do other special tests while they're lying on the bed. You'll be examining the patient both on their back and on their front. What I do is I say, can I ask you to lie upon the couch, on your back, head on the pillow, face the ceiling? And if they do, despite all that, lie on their front, I don't make an issue of it. I just examine them with them on their front to start with, and then ask them to turn over. Rather than saying, you silly old moob, can you turn over? Spinal palpation, so you have a look, you need to examine any masses or lumps, that's rare. Steps and gaps, you see occasionally, and you might be having a think about why they're nearly always at L4-5. And tenderness, and spinal tenderness, does it mean anything at all? We talk about facet joint tenderness, but it's under 4 centimeters of muscle. Does it mean anything at all? And then a neurological examination. This is very important. It's surprising how often you'll pick up a neurological abnormality, and it will refocus your thoughts about what's going on with the patient. And again, you need to have a system. So think about tone, power, reflexes, sensation. Some order in which you do all of these things. If you have a practiced order in which you do them all, and you've got a pattern in your head, you won't miss something out. It's very embarrassing if at the end of the neurological examination, someone says, so should we do the reflexes now? So you always need to have a pattern in your mind. These are some of the dermatomes. You need to have an idea of the dermatomes of both the upper and lower limbs and the trunk, of course. You must know some of the autonomous zones. It's no good just wafting your hand vaguely around the leg and saying that seems normal, because the examiner will say, so where's the autonomous zone for L5 then? And you say first web space, tick. And that's very important because there's quite a lot of crossover. Don't forget Cordra-Quina syndrome. In the exam, you'll never do a PR, but it's always worth saying, and I might consider a PR examination if I were in the clinic. You need to have a fairly good idea of what the myotomes are. And there is a pattern to this, as you all know. So the hip is L2-3 at the front, L4-5 at the back. So it just goes through the numbers. And as you go down a joint, it increases by a number. It's all relatively straightforward. You won't really be able to remember this in the clinic setting, but just have a vague idea of what muscles you might test for what particular nerve roots. So the examiner may say, I want you to test power in L5. And if you start by saying, well, I always start with the arms, the examiner will think you're bonkers. If you say, well, I'm going to test EHL, they'll be delighted. So you need to know what muscles are supplied by which nerve roots. So just have a think: hip flexion for L2, knee extension for L3. This is ankle dorsiflexion. We might have a discussion about whether ankle dorsiflexion is L4 or L5. L5, EHL, S1, flexor hallucis longus, and that fits with these reflexes. The knee L3, 4, ankle S1, S2. This isn't the way I do reflexes, and we'll show you much better ways this afternoon. And then some provocation tests. These are quite important, and you will often be asked about these, although it's quite rare to actually have someone in the exam, for example, who has sciatica. It's very common for you to have patients with widespread leg pain in your clinic, and you're trying to think, is this from the back? Is it a nerve root problem? Is it spinal stenosis? Is it diabetes? Is it vascular? Is it hip? Is it knee? And some of these tests will help. And certainly if you're seeing someone in A&E or as an emergency with cauda equina syndrome or some other dreadful nerve root pain, you need to have a think about some of these tests, which are the most useful ones. Laseg test, my test of choice, because the patients have never ever had it done to them before, so they have no idea that it's supposed to cause a lot of pain. The moment you put your hand behind the heel and attempt to do a straight leg raise test, certainly in Liverpool, and if there's a claim going on, you can't move them at all. What's the difference between the cross-sciatic stretch test and the well leg raise test? You just need to have an explanation for the examiner as to what they mean. They're completely different tests. They mean completely and utterly different things, so we might talk about that this afternoon. And these other nerve root tension signs. So the straight leg raise is your standard one, supplemented by the sciatic stretch test. That's fairly standard, and you need to have a bit of an idea about the femoral stretch test. And always think about the lower sacral dermatomes. I see quite a lot of patients with sacroiliac joint pain, I think, and here are some of the tests, and we might talk about some of those tests this afternoon, and we can show you these if you're interested. And always consider sacral stress fractures. I see a surprisingly large number of older patients nowadays with dreadful lumbar spine pain who turn out to have sacral stress fractures. Baton signs, someone else mentioned Baton signs. The rheumatologists think that ligamentous hyperlaxity is a common cause of back pain in younger individuals, and it's always useful to just be able to screen for ligamentous hyperlaxity for a whole range of orthopedic conditions. So if you could make it look slick and the examiner can't actually hear the cogs clunking in your brain as you're trying to drag these out, that's quite good. What L signs? Sometimes we talk about these, and this is just my little list on the left, DROST, for what L signs, which you may be asked about. Examination of the cervical spine. Again, it's look, feel, move, and you have to have a think about how you're going to do this. So I often have the patient either standing or sitting for this. Both are perfectly reasonable, and you need to look, feel, move, stand and sit the patient. There are some other tests. Walk the patient first, and sometimes you'll detect some abnormal gait which makes you think that they might have myelopathy, for example. And then coming down, complete neurological examination and some provocative tests. Have a look and see what's what. The only abnormal sign I can see in this lady is a possible fixed flexion deformity of the right elbow for some reason. But on the right, you know, cock-robin deformity, you'll pick up deformities of the neck, and you need to just be aware of what these are. You need to feel the cervical spine. So you've looked from the back, you've looked from the side, you've looked from the front. Scars on the cervical spine at the back are usually fairly obvious because they don't heal that well. Scars on the front disappear really quickly. So if you're at all uncertain, you need to just ask the patient, is that a scar? And the examiner won't mind. They'll think you're thinking. So that's good. And so you've looked, and you're going to feel. I do the feeling next. You do need to stand reasonably close to the patient. Use both your hands, and it's quite good to be able to watch the patient's face in a mirror. You need to know if you're causing pain. And if they're standing up, you don't want to be pushing them over. That's quite easy to do. And this can all be done with the patient sitting just as easily. And then movements. Movements of the cervical spine, flexion and extension, lateral flexion and rotation. You need to be thinking, where do these movements occur? So if a patient has no rotation, you might be thinking, oh, this looks like it might be upper cervical spine. How do you measure them? And there's the tongue depressor method, there's the tendon hammer method, and there's the just guesstimating it method. We'll talk about those this afternoon. Romberg's test is often asked about with the patient standing up, and you'll know about this. sensation in the dermatomes. So you've looked and you've felt and you've assessed movements, and you now come on to a neurological examination and other special provocative tests. So this is a diagram that I've got there, and these are some of the things. So most surgeons think the deltoid area is C5 and the index is C6. T1 is axilla, and C5 and T1 don't go to the wrist. But again, you have to know some of the autonomous zones, so you need to know, I'm going to examine here for C5, I'm going to examine here for C6, I'm going to examine here for C7, but there's a lot of crossover. You can say, and there is a lot of crossover. Think about the little finger and the ring finger and the middle finger. There's an important difference here between C8 and the ulnar nerve, and candidates are sometimes asked, so do you think this is C8 or ulnar nerve? And the poor candidate brains go to mush, and the good candidate says, well, here are the things I'm going to look at. I'm going to look at sensation in the ring finger. I'm going to, et cetera, et cetera. So think carefully about when you're examining the dermatomes. I just use fine touch. I just use my finger, and it's very rare that a candidate whips out hot and cold bottles in the neurological examination. It really throws the examiner. Muscle power and myotomes in the upper limb. You just need to have a quick way of whizzing through it, so that you should be able to examine all the myotomes and all the nerve roots in 30 seconds. You just need to have a plan about it. So, just make a pair of wings, keep your arms there, don't let me push them back down, bend your elbow, don't let me pull it out, push away from me. It just has to flow seamlessly, and as we said about examining the knee and examining the hip, if it looks fluid, the examiner looks fluid and practiced, and it looks as if you've done a neurological examination at least once before in your 6-year career, then the examiner will be reasonably impressed. Reflexes. Not quite sure, this isn't how I do the biceps reflex, though this might be a different type of reflex. We'll show you good ways of doing the reflexes, but you need to have an idea of what the nerve root values are. And so what is the implication of a dropped biceps reflex? You'll demonstrate an absent reflex, and the examiner will say, so what does that mean? And you'll go, oh, well, I don't know. So you do have to be thinking as you go along. That's really important. Some provocative tests, Sperling's test, you need to be able to know how to do that. The idea is you move the neck to nip the nerve and they get an increase in their pain. That's quite a useful test. You need to have a think about some upper motor neuron size. This is quite important, and we'll talk about this afternoon. And these are the ones that I tend to use. The Hoffman, the clonus is very easy to do. You've got the patient up on the table, you just do that. Just this week I saw a man who I was sure had a big disc prolapse in his neck causing dreadful C6 nerve root pain, up on the bed, marked clonus, and he comes back with a huge syrinx. So you will pick stuff up. So be very careful about that. And you can bet your bottom dollar if they do have upper motor neuron signs, the examiner's ticket will say, make sure they examine for that. And the examiner will say, anything else you want to do? And if you're lucky, they'll say, what about upper motor neuron signs? And then it'll suddenly click. So you need to have just some brief ones and a few of these to just go through. So today is about how to structure an examination. In other words, what to do. Eliciting physical signs. How to elicit these physical signs and make it look smooth and make it look as if you know what you're doing. But more than that, what does it mean? How do you interpret these things? And we're also here to clear up anything you want clearing up, but we're always too embarrassed to ask in the past. It's never too late to ask if you want some help. Thank you very much. Any questions? We can cover questions this afternoon, yes. Sorry? Well, usually they'll be provided. If they're going to be doing leg length measurements or Schober's test, there will be tape measures there. There'll be Coleman blocks tests. You don't need to take Coleman blocks tests to the clinic. The candidates I've seen where equipment isn't provided is, for example, the 5 types of grip. And so candidates will suddenly whip out of their pocket a little key ring with a key on and a pencil on and so forth. And you just think, not sure I'd have that in the clinic. And certainly, pulling out a pin and saying, I always test for pinprick sensation as a starter. The examiner says, this is orthopedics, not neurology, come on. And so forth. So probably not that much equipment. A tape measure may be the idea that in the exam, if there's tape measures, they're often paper tape measures, and they're not always that straightforward. So I'd probably take a tape measure, but probably not a lot. Yeah.
There's always a little bit of variation between autonomous zones. Is it reasonable for me to base mine entirely on the Asia charts, where they define each autonomous zone to do?
Yes. I think so. That's well standardised, well published. And if you worked in a spinal injury centre, you'll have undoubtedly used those. As long as you can explain. If the examiner says, are you sure? You just say, well, that's what I use when I do the Asia chart, and that'll usually shut the examiner up. Yeah.
Would in the exam come as a spinal case, and then we have to direct ourselves to this cervical or lumbar, or would that be?
Well, sometimes there's a lot of help. In the intermediate cases, it's 15 minutes, and it's all about taking a history, integrating your examination to fit that, and coming to conclusions. Whereas the short cases is very different. The examiner will say, this man has arm pain coming from the neck. Examine his neurology, please. It's easy, because he doesn't want you to get bogged down in doing 3 minutes of walking them up and down, because you'll get no marks, and you'll think you've done well, and he'll think you've done pants. So the good examiner will direct you to exactly what he wants.
And in cervical, we have to mention what role.
Have to mention what?
Horner syndrome, and we have to mention.
Just play it by ear. The examiner is there to guide you. Okay, he's not there to fail you. He's there to guide you. You fail yourself actually, but also he will tell you what he wants you to do.
Yeah, exactly. The examiners will tell you what to. So when you're looking at them, you can comment, I don't see any signs of a Horner syndrome.
We can take about 2 more minutes of questions related to lower limb or spine, and then we'll break for coffee, and then we'll come back. Any further questions?
So the lumbar spine examination, I'm sure it may be called afterwards, but you said prone position examining the lumbar spine?
Yeah.
I'm not sure what tests I'll be doing, because most of the tests I will do standing up.
You'll be pressing. You palpate the lumbar spine when they're lying down. So it covers palpation. So they're lying on their back to start with. You do everything with them lying on their back, and then you turn them over onto their front, and you just say, I'm just going to press on your spine, and I want you to tell me where it's sore.
But you could just do standing up to that.
Well, the trouble with that is you can't put much pressure on, can you? And the patient will think, he's not really pressing very hard, no wonder it's not hurting. Whereas if you've got a big mechanical advantage, you're a big heavy body like me, you can really press, and you can nearly always get some pain. Patients like to, oh God, you've hit the spot, doctor. You hit that button. Whether clinically it means anything at all, who knows? We imagine I'm pressing between the spinal processes. So if they have pain, it must be their disc. It's 6 inches in. Does that make sense? Probably not really.
So if we're back before 11th or just before, we may have a plan about how to split you up into groups.